Before we start our panel discussion, two quick comments. One is all the PowerPoint presentations from all 5 CEOs are online at the JU Public Policy Institute website, so you can get those. And second, I hope all of you agree with me that North Florida is really blessed with some extraordinary leaders and CEOs for the acute care systems here in North Florida. For our panel discussion, we have once again set up microphones at either end for those of you who may have some questions for the panelists. And I see that we have a questioner who's experienced at this. And so your question from the audience.
Yes, thank you so much. And extraordinary presentation. We should take all those slides, put them together. It's an excellent education. My name is Doug Adkins. I'm the administrator of an assisted living facility for the last 26 years up in Nassau County, and we deal with that low-income population. I can tell you, as we're dealing with rising acuity in the ALF, one of the things your hospital discharge planners are going to come back and report to you is there's no room at the inn. The doors are closed, the reimbursement's not there, the acuity's too high, we can't take them back to our facility. And so what's emerging here in North Florida is we've got an absolute rolling crisis with discharge planning. And discharge planners are very frustrated. And so what ends up happening is people end up, because they can't get back into a licensed facility, an appropriate licensed facility, they're ending up in homeless shelters, unlicensed ALFs, which, by the way, in Florida is a third-degree felony. And we're also doing all sorts of other arrangements. So my question is we're looking at integration and systems of care. I think it's really, really important that the hospital community look at your system of ALF beds throughout assisted living facilities for the elderly, the mentally ill, the adults with disabilities, to look at making sure we maintain a robust system, because these patients oftentimes, and I can tell you a lot of times when there's unscheduled care coming from our facility to your emergency room, it's being driven by the fact that the resident lives in a facility under the Resident Bill of Rights that it compels them to seek that assessment. The only reason they're in your ER is before the assessment, because there's a legal need to do that. We've got to remedy that. You could really taper off a lot of that. So the other thing that I wanted to mention is that Dr. Rupp, your organization has pioneered something called GenSight, which you alluded to just briefly, but it's incredibly important that the hospitals, as we're looking at chronic disease conditions, examine medication algorithms. I can almost assure you my staff are in contact with your staff every day of the 100 or so mental health residents we care for, and all the changes and nonsense that's going on and how we're managing care has just got to end. Algorithms for people with chronic diseases make sense. Dr. Rupp, you guys have a solution with GenSight in being able to genetically identify what array of medications they should be on, what the dosing level should be. So the innovations are there, but certainly I would like to hear, in terms of how you guys are dealing with the discharge planning issues, and certainly the integration would be very beneficial to us.
I can make a little bit of a comment on the first part, especially that you spoke of. I know at St. Vincent's Healthcare, and I suspect at other organizations at this table, are working to extend care into the homes of individuals now, so that we help them live independently at home as long as possible, bringing them the nurse practitioners and the care that's needed to help them to manage their health, their best possible health in their home. Additionally, we are I guess the only ones here at the table right now that are part of the CMS Bundled Payment Initiative program. And that program puts us in a position of looking at the entire episode of care for an individual, not only from prior to admission, but up to 90 days after discharge. And that has caused us to evaluate the utilization of skilled nursing, home health, and other programs, not so much the assisted living facilities, but the precursors to the assisted living facility. And we've identified that there is overutilization of a lot of those services for patients that don't really need it, and that should relieve a little bit of the pressure on those patients that do need those services in our communities.
The one other thing I'd add is my comments on integration. We have integrated poorly with you guys up to now. We plan to send somebody to a skilled facility, and we decide what information they should have instead of sitting down with you and saying, what information do you need? So I think we're going to see a lot more cooperation. We're running a couple of experiments now so that we can get patients rapidly moved out and do this 7 days a week or 24/7 and make it happen. But we've been way behind in that process up to now.
I would agree. And, you know, the point I made in my assumption is this management of care across the continuum of care is going to be that which we absolutely have to be about. And as Bill said, we've not done it as well in the past once they leave our institution. You know, we all tend to talk about what we're doing. Most of you are aware we've created a comprehensive geriatric institute. We call it the Age Well Institute. And the whole intent of that was really to treat the frail elderly, and the whole language of age well is to keep them independent and living in their homes, and therefore reducing the necessity but providing continuity of care. By the way, nobody pays for this. Let me just make sure you understand that. The average age is 82 that have come to age well this far, and have 4 chronic conditions and are on at least 15 to 18 medications. But if we can have that kind of continuity of care, therefore keeping people at a place where they're not needing to go back. And so I think all of us are doing our thing. Sometimes I refer to this whole area as transitional care, keeping people in their homes, doing better with the processes with discharge planning, other things that are on the preventive side. We have to be about this work. There are going to be no more skilled nursing beds in great numbers, as you point out, and so the no room in the end is certainly a very accurate observation.
Do you have another question? Yes, sir.
Yes, a quick comment and a question. I've had the pleasure, in a sense, or a learning experience, and my mother has been in three of four hospitals up there. And we're talking about health care delivery and Obamacare or the Affordable Care Act. But one of the concerns I had was once one's in a facility, I would see physicians who had access to data and information from other doctors, never looking at their computers when they came into rooms, and then asking the same questions again and again and again. So that's a comment, and I would say it's 4 of the hospitals up there, because I've been in all of them with my mother, and it's great if you have a safeguard for the person when they're there, because quite often they'll just run them off and do whatever. I have to also praise one of your hospitals because you saved my life. I was run over by a Ford F-150 about 2 months ago, and that was it. But the question I have is primarily for the for the Mayo physician, and that is when we look at genetics, and we look at and the things that we can learn when we're analyzing a person or persons when they come in, can we take that and look at treatment for a person before disease occurs, and then look at a wellness policy which can make it so people want to have extended life but don't end up in hospitals unless they have to at the very end?
The answer is, to your last question, is yes. I mean, that's what's ultimately coming. You know, the whole focus of the current healthcare reform is on treating populations and keeping them from getting ill. What hasn't been dealt with in that law is what you do with somebody who's very sick, when that 1% or 5% when they finally get sick. There's not a good idea of how to deal with that yet, but that will get worked out. But I think we're going to get to the point where we're doing the testing and telling you what your risks are and saying, here's your choice on whether or not you want to stay healthy. It's a little further off, but we will ultimately get there. One other thing on looking at health records. The young docs and nurses who are coming through now are incredible with the technology. There is a generation of us that are going to have to go away. So that it's fully utilized. But
You know, I add to that. My son is an internal medicine doctor at Vanderbilt. He told me the other day, I will never, ever practice at a place without an electronic medical record. And then he informed me in his entire training, he has never put a note in a paper chart.
Yeah.
You think about that. He has never put a note in a paper chart. That's the generation of physicians that are coming behind. So, you know, that world is going to change as those of us retire.
Is that the same thing as your son never returning a phone call? Because when I was just mine,
That's right.
Only just text, but it's the younger version, I guess. From our representative, we have a question over here.
Hi, I'm Representative Kerry Pigma. I'm also an emergency medicine physician. I'm the one who gives that low-quality, high-cost care in the emergency department. I'm guilty. I fully believe that with our primary care, we need to move away from a fee-for-service model into some sort of capitated risk-bearing model. Absolutely believe that. And we need to do a lot of things to get us in that direction. The thing I always struggle with is how do we bring the specialty care, particularly our interventionalist colleagues, into that picture? Will we ever be able to migrate away from fee-for-service in that circumstance? Is there some risk-bearing process we could have that would incorporate them, and they would be happy with being incorporated in?
You know,
You got the answer.
yeah. Well, I will tell you, it was very interesting spending time at the CareMore program out in California, where the PCPs are capitated. Then they have intensivists and extensivists that manage the patients that are, quote, out of control, and they consider someone out of control once they require hospitalization, or if you're not controlling certain manageable metrics, for example, with diabetics or hypertensives, et cetera, they kick up into the extensivists and hospitalists and out of the PCP's capitation pool, which is a relief to the PCP because they don't want the high utilizers in their pool. And then the specialists are acquired through clinics. So they have established clinics for diabetes, hypertension, end-stage renal disease, congestive heart failure, on and on and on. They have a litany of clinics, each of which are headed up by a specialist. It is very difficult to get a consult to a specialist. So in their program, the utilization of specialists has decreased 40%. It's pretty frightening, and I'm not sure not only is the healthcare system ready for it, but I'm not even sure our nation is ready for a 40% reduction in consumption of healthcare services. There's a lot of our economy that depends on it. So what they do there, though, is if that clinic can't manage the issue with the patient, then they may require the utilization of a specialist, and they only work with specialists that agree to their, as they put it, cult-like approach to care.
Yeah, the other thing that's coming is the electronics, obviously, and the ability to do much of this by distance so that the patients don't have to travel. The biggest headache around that right now is state licensing, and everybody's protecting their little piece of the turf. But we're doing it in many, many areas, and I think that's going to be one of the big advantages that helps cut that down.
Just to add, I do think that we'll go through a period of several years that will be very challenging, where we're going to have completely opposing incentives. It was talked about earlier that at some point walking through the facility and seeing empty beds is going to be a good thing, but it may be a good thing for a very small subset of the population. So I think as hospital administrators, we're going to want to accelerate as quickly as we can to go from what today is fee-for-service to value-based purchasing, because we're going to be in a transition period where, depending on which plan the patient is on, we could be incentivized to, the more you do, the better you get paid, to this patient really should be treated in a different manner. It's going to create a lot of confusion for several years, because it won't happen overnight in one fell swoop. It will happen over a period of many years, and during that time period, it can be very, very difficult to work through completely opposing forces.
Good. Take one last question from the audience, and when you're done, you can come back up. One
Hello,
last question.
Cindy Funkhauser, the CEO of the Sulzbacher Center. First of all, I want to thank you all. 4 of you have people on my board. The Sulzbacher Center for the Homeless runs a federally qualified healthcare center, 2 FQHCs in town. We provide high quality at no cost, and it is thanks to a lot of you folks up there who do support us financially in many other ways. What I did want to mention to you is there's no room at the inn. We just opened a medical respite facility, which Russ just came and visited last week. We have plenty of room at our inn. So when you're discharging homeless patients, you can discharge them to us at very little cost. We have nursing care on the floor. It's a very nice facility. So I hope you'll talk to your folks about that when you're talking to your discharge planners, because it's a great, it's a great place to send your folks. You can send your home health care there and lower your readmittance rate. So I just wanted to point that out, that we do have that available, room at the end. So thank you.
Well, thank you very much.
I just have to add, Cindy has done an outstanding job, but I was on the original board of the Salzbacher before that building became inhabitable for human beings. I remember running around the city getting drug samples from primary care offices in really putting in my trunk to get to the primary care site at Salzbacher. Boy, have you come a long way. Well, it's just incredible to go to the clinic that's there now, the quality of care, and now to the facility you've just created. I just have to commend you for your leadership.
Yeah, great.
Thank you. We're gonna have this session come to a close. I hope you'll agree with me that if you take a look at up here at this stage, this is a remarkable picture. And Hugh Green mentioned earlier the amazing collaboration that goes on. But if you think of these 5 acute care hospitals here in North Florida, what great institutions they all are and what great leadership they all are, and to see them all on the same table at the same time for today's discussion, it's really been extraordinary. I hope all of you will join me in thanking this group for this extraordinary service.